Durier with the Medical Society of DC, and health equity and access to care are important to MSDC. So today we're speaking with our partners at UnitedHeatlhcare, which offers a Medicare Advantage plan targeting individuals who are eligible for both Medicaid and Medicare among the city's most vulnerable populations. We get questions from our doctors about the different layers of benefits for dual eligible individuals. And so we ask the good folks at UnitedHeatlhcare to help us out with those today. And I am pleased to introduce Dr. Jomy Mathew, Chief Medical Officer of UnitedHeatlhcare, and Dr. Ricardo Berman, Director of Medical and Clinical Operations. Gentlemen.
Pia, thank you so much. We're really excited to join the Medical Society of DC in this webinar format. Really appreciate the opportunity and really look forward to meeting the mission of the conversation. Really is to kind of inform the constituents of the Medical Society about the exciting opportunities and kind of coordination of the dual choice program. We have some learning objectives, and I think we want to make this as informal, but I think it's just important to kind of start off where we're going. Ultimately, I think Ricardo and I are going to kind of go back and forth, but really at a high level, just review, right, Medicare and Medicaid, in addition to understand what does dually eligible really mean. There is an important component of understanding dual eligibility and the services that are provided, in particular, what is LTSS, and how an integrated dual SNP program coordinates this. There are additional benefits that I think will be really important for the constituents of the Medical Society to understand. And then ultimately how this is all coordinated and how it's done. That the how is really through a care model that Dr. Berman will speak to. And what that care model looks like, what's the role of a case manager in this scenario for your patients and for the providers. And again, to dive into a little bit about risk stratification. How do we identify the highest risk members and what does that sort of unlock or risk assessment mean? And then ultimately, how we effectuate or impact our enrollees, the members' journey, and it's really through effectuating a care plan. So with that, really, I think what's really important for us to kind of get started is understanding what coordination looks like and what the purpose of a dual choice program is. This interaction between Medicare and Medicaid can often be confusing. As Pia mentioned, oftentimes these are the patients, your patients that are stand to have the most risk, right? When you really start thinking about Medicaid eligibility, you're now starting to focus into places where social determinants of health really matter, and where the benefit of having a coordinated plan to address these is really what United is really excited to bring to the market for the first time, an integrated model. So what's the difference? I think, when we think traditionally about Medicare, we think about the flagship kind of governmental program that provides care for seniors. Now, some people with disabilities as well too, but 65 and older. It provides medical care coverage, but very limited, and we'll talk about this, long-term care coverage. There's no income limit per se. It receives federal funding, and we know that this is administered at a federal level, whether you're in fee-for-service Medicare or one of the new Medicare Advantage plans. Medicaid is the health insurance product that's that partnership with the state and the feds. And the state, I'll say the district. This is the main insurer for low-income children, some parents, seniors, and individuals with disabilities, and we'll talk a little bit about that. But it provides Medicare medical coverage, but also kind of adds that long-term care coverage, which really, when we think about the population that gets served in duals, we're talking about a lot of institutional care, right? Folks that end up living in nursing homes. This Medicaid has some eligibility rules based on income in certain categories. And as I mentioned, this is the coordinated efforts between the state and the federal level. And when administered, it is administered at the state level, but has federal guidelines. And we've known in the last few years about expansion in Medicaid, what that's offered across the country, right? And the superior outcomes in states, particularly that have taken that expansion to really get some of our most vulnerable members access to care. So dually eligible, what does that mean? It's really kind of the coordination of efforts, and we'll talk a little bit about what's on one side versus the other. But oftentimes, if these benefits are siloed, it's not coordinated. What that means is that patients and providers can get very confused as to where to go to for what. UHC is, as of February 1st this year, we're excited to partner with the district to kind of fold this plan in together. And so ultimately it is this, coordinated provider plan that, or payer plan that will coordinate the efforts to provide medical care coverage through Medicare and long-term care coverage through Medicaid. And we'll get into some detail. Now, what this also means is that there is a coordinated effort from a standpoint of payment mechanism. So Medicare may be the large portion, for example, in a certain kind of a provider service, but Medicaid is considered the payer of last resort. And we'll get into some more details about what that looks like. This is, again, funded by both state and at the federal level, but it is administered at the federal level with state requirements. So it's a little bit on the a little bit different than Medicaid, but ultimately UHC, with our knowledge and experience both at federal programs and state programs, district programs, that's why we're positioned well to administer this program. I'll go to the next slide. So as I mentioned, these services kind of have some buckets or some swim lanes. And for the most part, when we talk about Medicare, right, the traditional costs, especially in a dually integrated program, the Medicare side, are the traditional things that providers think about: hospital costs, skilled nursing facility costs, primary care services, home health services that are skilled, most DME, some of our FQHC partners as well too, from a standpoint of the dual program, X-ray lab services, pharmacy. So it really does have that filter or layer to kind of go through the Medicare component. But as I mentioned, Medicaid criteria and Medicaid funding sources are also kind of passed through here. So there's coordination. There are some services that are frankly just Medicaid only. And the reason why these programs show superior outcomes is that we're coordinating these, because it's really important to coordinate these benefits for our patients, in particular long-term care. So I kind of gave that definition earlier. Custodial nursing home care is paid via Medicaid. There is an important suite of services that we call LTSS, or long-term care support and services and support. These are really those home and community-based services. Typically these are PCA services, the non-skilled supports that help individuals age in place. Private duty nursing, for example, for really specialized nursing needs that require. These are some of our most frail seniors or frail patients that require a lot of help at home. Coordinating these efforts is a key linchpin of the Medicaid program, and now folding this into a dual choice program allows for tight coordination from a standpoint of what happens in the four walls of a doctor's office to what happens in the patient's home. And we'll talk about how we get there. There are other benefits, from the district perspective, like non-emergency transportation services, optometry and dental sort of care, all sort of folded into this. So, what is the benefit of the D-SNP program? It's coordination of these benefits. It's one-stop shop, plus some additional services that fold into this. And we're excited to share about the additional benefits that the UHC plan has. Go to the next slide. So again, as I mentioned, what is a D-SNP, right? It is a health plan for people who qualify for both Medicare and Medicaid. The elderly, those folks over the age of 21 with disabilities and have limited incomes, right? So that's sort of the other kind of qualifier. These individuals have to be registered in these programs. As I mentioned, this is a federally administrative program with state requirements. You have to fold into where these programs are offered. And so for the district, clearly you have to be a district resident. And the coordination of these efforts are really kind of folded into the bounds of the service area. Although Medicare has that ability to kind of go outside the district, there is still that coordination that happens, and your address has to be in DC. So as I mentioned, hospital stays, doctor visits, your prescriptions, the coordination of care that is all important between Medicare and Medicaid, those additional benefits. The examples that I raised before were dental, and I'll be talking a little bit about social determinants. D-SNPs can just make healthcare more affordable and easier, right, for patients and providers to negotiate or navigate. We're optimally positioned, right? When you think about it, there are high value benefits and services that Medicare can provide, but there are holes in coverage. Same thing with Medicaid. The fact that it's all under one house allows for us to get the care at the right time for the right patient for the right amount. It really is the focus of bringing value into how care is provided. It's a comprehensive package. It's really focused on the patient. We talk about terms like consumer. It is consumer centric because again, when you qualify if you're dual choice, there are these social determinant factors that really are clearly part of the reason that certain health outcomes and inequities exist. And so the ability to fold all of this into one place allows for us to provide those additional benefits. And the coordination, as I mentioned. We improve quality by coordination, and in coordinating efforts around the care of patients, it lowers costs. Access to more services to receive this more coordinated care, improving patient compliance by meeting patients where they are. And we'll talk a little bit about that in the way that our care model is set up. We deliver value, as I mentioned, through care coordination, and through care coordination leads to more appropriate utilization. I was just in a primary practice yesterday, kind of giving this overview or talk, and there were particular questions about, I've noticed one of my patients really could benefit from having a home health aide help with certain aspects of ADLs. How do I find it? Where do I go? This program, and what I was able to do is connect the dots, and I think that's what this program intends to do. Really, by delivering care at the right time, we avoid unnecessary, for example, senior cells and not having their ADLs met, which can lead to falls. We can lead to development of wounds or infections. So being proactive about this identification and connecting care is really, we'll get to the outcomes that we want to see in the care of these individuals. As I mentioned, there are additional benefits that are not provided in a typical Medicare program and in typical Medicaid. And that's really what's really important from a standpoint of addressing social determinants of health. UHC has an over-the-counter and healthy food benefit. $80 a month is provided to all of our members, your patients in this program, for it's a prepaid card, $80 a month for OTC products and covered groceries at many retail delivery. Meal delivery, up to 14 meals for up to 7 days right after a hospital stay. We also are proactively trying to address frailty by enrolling our members and having rewards around a fitness program. So reduce costs or no costs for gym membership and or exercise activity based in the home. Additionally, a major barrier for some of our members to get to physician practices or to the pharmacy is transportation. We're able to provide 24 one-way rides or that non-emergent sort of care visits for medical doctor visits, getting prescriptions. It's a $0 copay. So these are several of many benefits that an integrated program is able to do, and we're able to identify and connect these benefits to our patients. And so, again, when you put it all together, this is really how a dual choice program really does impact the journey for the enrollees that we serve. With that, I'm going to pass the ball over to Dr. Berman to talk a little bit about our care model, the mission and the strategy. Dr. Berman? Dr. Berman, you may be on mute.
So thank you, Dr. Mathew. So thank you for this opportunity to talk to our colleagues and providers and explain more about this new plan that we offer in the District of Columbia, and to understand better the integration of Medicaid and Medicare services. So, but let's talk about our care model overview. Special needs plans must be developed and implement a model of care. So our model of care is evaluated and is approved by NCQA, that is the National Quality Assurance Organization, and CMS for Medicaid and Medicare services. Our model of care also provides a structure for care management and coordinations of services as well. Next, please. So now let's talk about how is our simplified way of the experience that our enrollees get into our healthcare plan. So as you can see in the center, you're going to find the enrollee or member and the case manager, and gravitas around them a team or what we call ICT, interdisciplinary care team. This is one collaborative local care team that's fully integrated and work in an individualized plan. Our ICT provides a seamless care for our members, provide care management, follows evidence-based practice, person-centered model. Also, our team partners with preventive healthcare systems, partner with DME companies, the other medical equipment, diabetes suppliers, also behavioral health systems and services, including opioids and SUD treatments. LTSS also includes services my way. That is when the member make the choice that their care should be provided by a relative or a neighbor or someone that they know, with excellent results because they already have the rapport between the member and the caregiver. Among those services, we have dental, vision, pharmacy services, non-emergency medical transportation, and alternative services such as cost-effective and specialty care services. Our enrollees also into the holistic way. They benefit for the case manager, that is the quarterback, or what they receive. And the case manager really core work is to ensuring the access to the PCPs, mitigation and addressing the SDOH, the social determinants of health, which is something that really affects our population in the district, and something that as an organization and plan, we focus very closely about looking at those aspects in the communities or in the environment of enrollee that may affect their health. The case manager also coordinates care, finding enrollees who are unable to reach through different sources. Sometimes they move to different locations, or after they are discharged from the hospital, they cannot be found for primary care physicians' offices or even our plan. And we have different ways to find them out through different resources, as I was looking at information that's coming from pharmacy, from billing, the last time that they visit the hospital, the information that they completed, and we look at those demographics. And we share also with the providers when they asking us if we know how to locate one of the patients. That is part of the supporting gaps of care that the case manager worked with too, and nursing facility repatriation is another aspect where the case manager working in this environment, and the HCBS, that is the home care-based provider services, that is part of the core of the LTSS program.
You know, Ricardo, I think the one thing that this slide really typifies is potentially how complex, you know, the circle is, right, for patients and for our enrollees. You know, usually it's not this coordinated, right? Many of these dots that are kind of forming this nice circle around the centerpiece are typically disparate and not really knowledge of each other. So those dotted lines are typically not there. The goal of the program, right, is to kind of keep everybody kind of moving around and the information is being shared. And I think we talk about this, but I think that's why that enrollee and case manager are in the center, not just from a standpoint of, you know, who can pick up the phone, but making sure that it's the enrollee or, you know, kind of enrollee-centric or patient-centric approach. We create these care plans, and we'll talk a little bit about this from their focus. It's their point of view, and it's empowerment. You know, I see also on this, you know, kind of circle is the caregiver, and we know many of these members, it takes a village to support, and this is evidence of the village of folks. An important and underutilized, you know, kind of layer to that support is the caregivers that many of the patients have in the community. And it's not just that, faith-based communities are part of that story as well too. Our case managers are basically there with the members where they live, right, to try to coordinate all these efforts and translate to get to the goals that really are mutually agreed upon.
Absolutely, Dr. Mathew. And let me add to that what we see in this slide, many of the services, they are shared or they may belong to Medicare or Medicaid. And the enrollee of the providers, they don't have to think how they're going to address each one of those. The whole purpose is to have one centered experience is that we take care in the back end of how this process goes through Medicare or Medicaid. So just the providers can focus in really exercising the practice and the best from the enrollees, and the enrollee can focus in just to have the experience and focus in their self-health care. And that's the main point of it. But thank you for that. Next, please. So now let's talk about our risk stratification. We stratify our population from levels to 1 through 4. Our population goes from a stable risk, that is, as we can see, number 1, all the way to high risk. However, the LTSS population falls into the highest risk. Every individual enrollee that they are in the LTSS program, they automatically are into the highest risk, which obtain the benefits of have a monthly case management visits, advanced practitioner visits, and all level of interventions, and they have a case manager that is assigned to them, which keep in contact in a monthly more than once per month, with an average between 4 to 5 contacts per month, because we know all the needs that the population may have. So I would like to go next, please.
Yeah, Ricardo, the only other comment I was going to make, and I kind of gave that scenario of being in a provider practice yesterday. This emerging risk is important, not just high risk and stable risk, but those folks kind of moving up the chain. This is part of that proactive effort. And so making the connections earlier, right, helps prevent and sometimes delay, right, high risk events. And so I think that's what really is also important, that this is about proactivity, and in some ways as well too for the providers. You all see some of this sometimes within your visits, right? Hey, the fingernails a little bit longer than the last time, or you see folks that are disheveled. These are the ways, subtle things, right, that talk about if there's been a change in condition. To me, risk stratification, you can have all the algorithms in the world, but a good clinical eye can also kind of find this. And I think it's important for us to connect the dots and to understand what supports are out there. So I kind of use that also as an opportunity to kind of make sure that the providers at Medical Society also understand how important they are in this role of identifying emerging and rising risk.
And you mentioned the tools that we use to do the certification, which I'm going to comment a little bit more about them. So we take information from claims, we take information from pharmacy, we take information such as how many times an individual has been in the emergency room or been hospitalized. And this is how the risk levels are determined. However, they are not set in stone, right? A provider, if a patient of a provider appears in risk stable or 1, but he or she thinks that it should be higher level for reasons that you just mentioned, right? The eye of the clinician is a different than a tool. So those risks can change. The same, the case manager can do the recommendations to change the level of an enrollee. So yeah, those are important tools that is really good to keep in mind, and that we share that information with providers about how their patients fall into the different strats.
Perfect. Yeah, I think it's a great segue to kind of how we communicate that, the care plan overview. Go ahead, Ricardo.
Yes. So now let's talk a little bit more. We mentioned about care plans, and we're going to talk a little more about how they are put together and what is the goals. This is the care plan overview. Those are assessments that identify opportunities and problems. You see in the 3 areas in different colors: the opportunity, the goal, the intervention, and then the care plan. So let's start with what follows the assessment. Is the development of a solid care plan that compromises opportunities and interventions and goals. On assessments, identify members' needs, problems, or gaps, and those gaps in care that we refer that such as opportunities. So for us, problems, gaps, they may be opportunities to address to improve the health as a whole. Each time that we interact with a member and conduct an assessment, we are capturing details in the intervention within the member electronic medical records. The majority of what we discuss through the assessments and interventions and goals are documented into the care plan. Each opportunity we identify as an opportunity to do an assessment that requires plan goals and appropriate interventions and the assessments. Assessments are a very important piece of it because responds to specific questions in a way that is indicative for us if we have needs or gaps. The assessment automatically triggers the development of an opportunity or goal or an intervention. We prioritize with the member those goals and we choose between 3 to 5 that they are the ones that we're going to address during that period of the care plan. So for instance, if we identify that there are 10 goals or 10 opportunities, we choose the top 3 or 5, depends on how complex they are in collaboration with the member. Enrollees are a vital part of the process because they need to work hand to hand with the case manager to achieve goals. Multiple people are involved in the creation of a care plan with the enrollee participation and provider participation and coordination of care. When we talk about provider participation, that includes the primary care physicians. At minimum, the care plan will cover areas like physical, behavioral, social determinant of health that we spoke about recently, and including self-management, wellness goals, and activities of daily living, crisis plans, and advanced directives. At the minimum, the care plan will cover the physical and behavioral health needs and social needs. The opportunities that we encounter addressing goals and interventions make as a whole what we call the care plan. And the care plan has to be measured and the goals have to be achieved. Care plans are dynamic. They are documents that I describe them to be alive because we review them. It could be reviewed or every quarter, but for the highest risk, like LTSF, they are reviewed monthly and they are updated monthly. And we call this the members' health journey, which we're going to talk about that following this slide. Care plans are not static. They may change for reasons such as visits to the emergency room or changes in circumstances with the caregivers, with the enrollee. So after that, we reassess and we readjust the goals. Now, let's talk a little bit more about how is that member's journey.
Absolutely, Ricardo. Kind of pulling it together, I think a nice way to kind of conclude our talk is to literally pull a member journey right from our experience already since we've kind of gone live with this health plan. And as Ricardo mentioned, this is dynamic, and some of this is just kind of putting in action what we've kind of described. So we changed the name, of course, but Cindy Johnson is a 56-year-old female with a history of diabetes and COPD. She currently was living in a senior living apartment. Cindy has been an established dual choice enrollee member, but as part of that kind of stable to rising risk, an APC visit identified on their visit that there was a change in function. The APC essentially noted this in their routine sort of follow-up and said, hey, something's different, something's going on here. So they got in touch with the case manager, say we have to kind of determine if there is new needs that the member needs because of this change in condition. And so the care manager then works closely with the district's process of determining a level of care. And it is a process to kind of help unlock some of these benefits. The case manager does a face-to-face visit with Cindy and her caregivers to discuss the options, facilitate the level of care determination, as Ricardo was talking about, in order to unlock certain benefits in the Medicaid space. We have to kind of provide that application and the process points. Our case manager helps the patient and their family kind of do that. The person-centered care plan is developed and it's shared with the senior living center. This member was approved for home health services. to be provided to help with those additional functional declines and to meet those needs. This care plan was developed, shared with the Senior Living Center, with the patient's provider and the family. The case manager takes that next step of not just simply agreeing on the plan, but starting to process the authorization through this, because we know that healthcare is very complex. This is not just simply about yes, yes, and shake a hand. It's about kind of making sure that setup, that payments work, that care is provided timely, and that there's oversight. So the CM initiates the authorization about the agreed upon services, approval letters are sent. Every around that concentric circle around the patient is aware of the care plan. And finally, a care conference is set up with Cindy and the caregivers at any time, right, to discuss progress. As Ricardo mentioned, these are monthly check-ins to make sure that the member is meeting the goals that we set off to do. So it's not just a one and done. Ultimately, at the end, the case manager has completed the face-to-face visits, met the needs, and has that ongoing sort of follow-up. I mentioned the monthly follow-up for the care plans, but every 90 days, there's a evaluation to kind of make sure that the services that are being provided still meet the goals and that there's been no new changes. At the end of the day, this is what care coordination really looks like. It's complex, but we want this one-stop shop to really deliver care. I know providers on the call, in scenarios like this, well, I'm worried about my patient, but I don't know necessarily how I could proactively get some of these services in place. Oftentimes stories like this end with an unfortunate emergency room visit or hospitalization with a fall and hip fracture. And then we know the trajectory of our frail seniors potentially changes completely. So I think these are interventions that really speak to what we want to try to accomplish. How do we deliver a more coordinated experience to translate to better value and better healthcare experience for patients in the district? This concludes our topic today. I know, Ricardo, we want to make sure that folks are understanding and aware of all these benefits of this program. But if you all have any members or patients that are members of Dual Choice Health Plan and you have questions simply about care coordination, we left an email address that you can certainly inquire. At the end of that email will be a care navigator that will pull in the details and connect the dots. I wanted to make sure that we left a little bit of time, Pia, for any questions that may have kind of come up through the Medical Society's commentary.
Thank you, Dr. Mathew. And in the bottom of the slide is the email address, the dc_uah@uhc.com. This is where every provider can communicate with us. We reply within 24 hours. And we encourage our community of colleagues to get in contact with us because part of this journey is the primary care physicians. And working together, I think that we can have a more healthy population, more stable. And thank you so much for the invitation. Now I think that we have questions.
Yeah, thank you both. And really kind of like outlining everything that you did. I think it certainly gives us a lot will give our doctors a lot of insight. But of course, one of the important issues for doctors that we do, want to make sure is that they know how they can get reimbursed, and sometimes, that issue of reimbursement is complicated when there's different layers of agencies or programs. And some of the questions that I think we've gotten are just related to how do you get reimbursed for the plan? Does a doctor need to be enrolled in both Medicare and Medicaid if they want to get the remaining reimbursement? How does reimbursement work for doctors and for providers?
Yeah, I think it's a great question. I know we've kind of highlighted what coordination looks like from a standpoint of all these services, but ultimately one of the points of this program to be integrated this way is to make that experience seamless for providers from a standpoint of reimbursement. And as you mentioned, likely in the past, there was submitted claims that have to go to the Medicare payer and then would have to go to the Medicaid. This is an integrated program that also includes payment. So that's why I think it's important for providers to be registered under the Medicaid product with the district, because it allows for kind of one-stop shop literally for provider payments as well too, and reimbursement. And that's really what an integrated model looks like. So when you submit that procedure to United or the claim gets dropped, it automatically filters in through the Medicare and the Medicaid. And what's sent, right, an approval has both sort of approvals, and the adjudication of the payment, right, is done that way. So that's why I think it makes sense. We're behind the scenes kind of putting it all together. So not just what's in front, the care coordination, the coordination there, but behind the scenes, the coordination of all these benefits and payments. And that's integral, right, in kind of delivering that experience for providers. So I'm glad that you asked that question, but it's par for course, right, for an integrated model.
Thank you. Thank you very much.